Hey, it's Loz and Ben again.
Today we're doing the upper cranial nerves, which is primarily all of the cranial nerves relating to the eyes and also olfactory, the first nerve. So as with any examination, we start with getting hyped, H-I-P-E-D, and if you don't know what that is, check out our first video on the upper limb neurologic examination. The first nerve to examine is the olfactory nerve. This observes the function of the sense of smell. Typically, we simply ask the patient if they've had any difficulties with the sense of smell, as it's quite difficult to test this and also difficult to demonstrate laterality given the location of the nostrils. Lauren, have you had any difficulties with your sense of smell?
No.
The second nerve is the optic nerve, which we use for the afferent limb of the visual system. The way that we test this nerve is with the Snellen chart, and typically at the bedside we need to use the near chart. The downside of this chart is that it requires the ability to accommodate for near vision, which is why you'll often find people use distance charts. It is also important to ask the patient if they normally wear spectacles for reading. If they do not, as Lauren does not, then we use the pinholes to eliminate any refractive error, as we are simply interested in the back of the eye in the neuro-ophthalmologic examination. Lauren, can I get you to hold this over your eyes, please, and with your right eye, look through those pinholes and read the lowest line that you can see.
GTZS.
Keep going.
ENOGH.
Next.
SFERUB.
Can you do the next one?
UGNZFS.
And the last line now.
LCYREHS.
Excellent. So as we can see, Lauren has 6-on-6 vision when she uses the pinhole. The next thing we like to look at is the left eye's visual acuity, corrected with pinhole. Lauren, can you put the pinholes over your left eye? Please read the lowest line that you can.
SFZNQU.
And try that bottom one for me. I just want you to guess if you can't see all of them.
SHERYCL.
Excellent. It's always important to ask the patient to guess another line, as they're often reluctant to do so, as no one wants to get things wrong. But in this example, Lauren was able to read each and every one in the 6-on-6 line and happened to make one error in 6-on-9. The result, of course, is 6-on-6 vision, corrected with pinhole. Cranial nerve 2, the optic nerve, begins with inspection of the eye and surrounding structures. We're looking for any ptosis, which is lowering of the eyelid, but as we can see, there is some iris seen between the eyelid and the pupil, which is a normal feature, and symmetry is preserved. We then move to the iris. Sometimes we can see signs of medical disease there, such as Kaiser-Fleischer rings of Wilson's disease. And then we move to the pupil. What we want is for them to be equal and also round and responsive to both light and near reflex, both directly and consensually, and I'll show you what I mean in a second. One of the important bits of the pupil response to light is this consensual response, and what we can bring out is a sign called the relative afferent pupillary defect. And as the name suggests, it is a difference between the afferent limb of the visual system on either side, which means that when you shine the light into one eye, it doesn't constrict quite as much as if you do it into the other eye. The way to bring this out in examination is to flick the light source from one eye to the next, and the eye that is abnormal will paradoxically dilate its pupil when the light is shined upon it, as it was already constricted when you were shining on the contralateral eye. The next part that we examine in the second cranial nerve is visual fields. Lauren, can I get you to cover one eye, but don't push the eye in, we're going to need it in a second. And what we do as the examiner is we close that eye. What I'd like you to do is to look at the tip of my nose and point to the finger that moves. Excellent. We can also test for neglect in this manner, as you just saw. Excellent. Cover the other eye now, please. And now I'm closing my left eye, tip of the nose, point to the finger that moves. Great. That's normal. The next part of the examination is funduscopic examination, which is where we look into the back of the patient's eye. Now this will be difficult to see what I'm seeing, but I will run you through how we perform this. First, get your ophthalmoscope, which is hopefully a pan-ophthalmoscope, which is able to see far more than your traditional old direct ophthalmoscopes. We turn on the light and we use the smallest diameter light, as you'll get less constriction from the patient's pupil. We also ask them to look into the distance and focus on one spot only to maximise mydriasis. Lauren, can you look into the distance for me? I want you to pick one object and just focus on that for me. I then use my right eye to look at her right eye. We move in at 20 degrees and we are able to see the optic disc. You may need to focus with your thumb. However, this is okay in Lauren, and we can make out the optic disc and its margins. We also do this on the other side, and the other important thing to note is spontaneous venous pulsations. The next function to test is colour vision, and the first colour that's lost in an optic neuropathy is red. For this reason, we can use a red neurotip as the object of interest. Lauren, I'd like you to look here at the redness of this neurotip. Cover one eye for me. Now tell me, if you change that cover over to the right eye and look at it with your left, does it look any brighter or any dimmer?
No.
Excellent. You'll often get the patient to try that a few times, and you can also try with brightness if you have a bright enough pen torch. We're now up to ocular motility, so we'll be looking at nerves 3, 4 and 6, which are oculomotor, trochlear and abducens, respectively. The first thing to look at is primary gaze. So Lauren, if I can get you to actually look into the distance there for me and just pick one thing only. And as the examiner, what we do is we cover the eyes sequentially and we just make sure they're both pointing in the same direction. If somebody has a strabismus, you will note that when they are forced to fixate with the eye that is either exotropic or esotropic, or indeed up or down, hypertropic, hypotropic, you will see that that eye needs to fixate once you've blocked the good eye. This is very useful in your examination. We now move to the movements of pursuit. Lauren, I'd like you to follow my finger here. I want you to keep your head still and with your eyes just follow the finger. Tell me if you see 2 or 1. What we're looking for is any nystagmus, which is flicking of the eye, or any double vision or disconjugate gaze. It helps in downward gaze if you listen to the patient's eyes. The final bit of eye movements is looking for convergence, which is done with the near reflex. Lauren, I want you to look into the distance at that spot again, and then when I say, I want you to look at my thumb. Thumb, distance. Thumb, distance. Sometimes we can also bring in the target and watch the convergence, meiosis. Accommodation will also occur, but we cannot see the lens, of course. Follow my finger as it comes in, Lauren. Excellent. The near reflex is preserved. And the next major voluntary eye movement is saccades, which is where we flick the eyes to objects of interest in the environment. The way we test this is as follows. Lauren, when I say thumb, I want you to look at my thumb, and when I say finger, look at the index finger. So thumb, finger, thumb, finger. Excellent. What you're looking for is if she undershoots and needs to do a few hops, which would be a hypometric saccade, or if indeed she overshoots and has to come back, which would be indicative of cerebellar disease and a hypermetric saccade. The final thing with eye movements is thinking about gaze as well, which is different to the oculomotor abducens and trochlear nerves and is actually a higher function, and as such it's referred to as supranuclear. The way we would test this, or at least distinguish a supranuclear disorder from nuclear or infranuclear, which are those that we would have just detected, is we turn the patient's head and we try to have her focus on one spot only, and if we're able to achieve that movement doing that but otherwise not, that actually indicates a supranuclear palsy. The last test of the eyes actually tells us about the function of the 5th and 7th nerve, and that is the corneal reflex. This can be a little uncomfortable but can be really quite helpful, as you will get, again, a direct and consensual response. I'll pop some gloves on. What we need is a bit of cotton wool, and we'll ask Lauren to look up there to the top left, please. And what you need to do is actually just to very lightly touch the cornea and look for the blink reflex. And that's not the conjunctiva, which is over the white sclera, but rather the cornea over the iris and pupil. Look up to the top left for me, please, Lauren. This can be a little uncomfortable. And as we can see, once we touch the cornea, there was an obvious blink reflex on both sides. That concludes the examination of the upper cranial nerves.